Chapter 37, Emergencies with Patients with Special Challenges. Before we get started, don't forget to like and subscribe for future updates. Let's start off with kind of a definition of what patients with special challenges are. And this should go without saying, every patient deserves your empathy and respect, but those with special challenges take a little bit more concern and a little bit extra time. So you have to be really good at making sure they understand you're there to help them and you're going to do everything you can for them. We'll make sure we have the right terminology here. Disability is a condition that interferes with the ability to engage in activities of daily living. We no longer use the term handicapped. Disability, access, functional needs are the current terms that help describe these people. A developmental disability is a chronic impairment beginning at any age up to 22. Cerebral palsy, Down syndrome are two of the common ones we see. Could be something that's a result of a traumatic injury or a medical condition, MS or multiple sclerosis, Parkinson's. A stroke leaves a person in the condition that they're going to need have special challenges. Traumatic brain injury or spinal cord injury all cause additional needs that we're going to have to adjust our care and our way we treat our patients. Because of all the advances in technology, a lot of our patients are living independently. They can take care of themselves pretty well with very minimal outside assistance. So you may get a lot of calls to people that normally would have some type of healthcare provider there or someone to assist them, but because of the advances, they are by themselves. Although some of them do have that extra person there with them, so just kind of be aware of what's going on and adjust as needed. When you're dealing with a patient, you may have to adjust your style. Typically, we don't have our patients touching our faces, but if the patient is blind, that's how they connect with you. So get down on their level, make sure they understand you're there and where you are, and use some extra care when taking care of these patients. We also have patients who are terminally ill that are living in homes. Thanks to hospice, they're getting these patients back to a home setting where they're more comfortable and the family can be around them all the time. These are typically like your end-stage cancer, heart failure, Lou Gehrig's disease. They'll be at home. They may have some hospice care there with them, or they may just have family that's helping them take care of them. They may have hospital-style equipment, ventilators, feeding systems, IV systems, but they're all there to help them have a normal life. Most of these patients, because they are in the terminal illness stages, they have advanced directives in place, and they will typically have those available for you as soon as you walk in the door. Another special challenge we're seeing more of in the EMS community, we have obesity, people that have a body mass index over 30. Typically, we're seeing patients 300 to 400 pounds that need some extra assistance. We're going to have to use some special technology, some special tools to transport them. We have bariatric ambulances that have the right size cots and the assistance to get them into the ambulance, and has an extra floor space so we have room to transport them comfortably. So you want to be, when you put them on the cot, you want to make sure you're not putting too much pressure on their lungs so they can't be laying supine. Make sure you keep an eye on the airway. Keep them in a ramp position, that's a semi-Fowler's position. And make sure you have plenty of help when you're moving the patients. Get as much as you need. Bring in the extra firefighters, another ambulance, whatever you need. And make sure you have the right size equipment. Homelessness and poverty, another challenge we're facing. One of the problems with the homeless population is they have a lot of untreated or not well maintained health conditions. So they'll end up with pneumonia. They typically have a lot of mental health issues, malnutrition, substance abuse, chronic conditions, communicable diseases like HIV and AIDS. They don't have access to everything that people have on a regular basis, so their health care isn't kept up. So they may be calling 911 for those things that you're going to have to provide a little extra care for. Sometimes we have abuse of the homeless population, and there's typically a lot of emotional issues, especially if you have kids that are homeless. They're concerned that they're being judged for being homeless. Give them the support you can, and do what you can to help your local communities. So some approaches to caring for patients with special needs. Autism is a uh, developmental disorder that affects the ability to communicate. Kids with autism uh, do not communicate like other children do. So we have an acronym that we use, ABCS, as opposed this is different from our ABCs for the primary assessment. So we have awareness, basic needs, calm, and maintain safety. So awareness, we're talking about making sure that they know what's going on around them. They do not like change. They sometimes have difficulty communicating, so you may need to take some extra time and listen to them. Take your time with all patients, but especially with the autism kids. If they're having a meltdown or escalation, try to find out what calms them down. Help them understand that you're there to help them, and use the caregivers as much as you can. Basic, keep your instructions very simple and clear. Ask basic questions. Don't bring in extra noisy stuff like your radios or your cell phones. Keep it just you and your patient and the caregiver. That way there's not any extra stimuli that's going to cause any problems for them. Keep them calm. Use one-to-one contact. Um, use the caregiver as much as you can. Keep a nice, calm voice. Talk to them and be willing to listen and take your time. If it's not life-threatening, you've got time to work with them. Begin treatment where your patient is found. If they are complaining about things, they don't like the color of your jacket, take your jacket off. This is one that you would do just like a pediatric. You do the toe to head survey, because as soon as you start irritating them, they won't let you finish their assessment. So start at the bottom and work your way up. If you ask a question, be polite and wait for the answer. And give them the time to relax between your questions. Find out what calms them down, keeps them from being agitated. A friend of my son's who's autistic, a Rubik's Cube calms him down. You give him a cube and he will relax and go back to being as calm as he can be. So the other thing about autistic kids, and pretty much any special needs kid, don't restrain them. That's just going to irritate them, and you're going to be surprised at how much strength they have anyway. Special needs medical challenge. You got kids with lung disease, heart disease, neurological disease. They're living at home. The parents are the caregivers. They may have trach tubes, be on respirators at home. There are so many different types of home healthcare equipment that as an EMT, you would never be able to keep up with all the different systems out there. So you use the caregivers as your source of information to tell you what's available, what's the possibilities to fix the problems. And then there are your great source of information. Most of your parents of special needs children or other patients will know more about the disease process than anybody you ever thought. So some special considerations. When you find these advanced medical devices in the homes, don't assume you know everything about them. Don't try to adjust them unless that's in your protocols. But know that they're there and use the resources that you have to try to solve the problem. Call tech support. Call their 800 number that's on the device and say, hey, I'm here with a patient. The family member's having issues trying to get this reset, and they called us, and I'm trying to help them out. What can we do? So use all the resources you have. So this is a kind of example of what you might find. The patient's on a ventilator, they've got a feeding bag, and they've got an IV bag set up. So you've got all kinds of devices there. Don't start messing with the dials unless you know what you're doing or unless you've conferred with the experts. You may be going to private residences where you have these people, but you may be called to nursing homes or other group homes, specialized care, rehab facilities. Just follow the lead of the healthcare provider there if they're credible. Sometimes you get there and you find out they don't really know what they're doing, so you have to adjust and maybe call medical direction and find out what else you need to be doing. Develop a plan of what you're going to do and find out if there's any other resources to help you with this. Caregivers, like we said, are very familiar with the equipment, so ask the questions. Have they had this problem happen before, and how did they fix it? Have you been taught how to fix this problem? Have you tried to fix it, and what happened? Usually they try to fix it on themselves before they call 911. It's when they got into trouble or something didn't work the way they thought it would that they actually turn around and call 911 for your help. So listen to them. They are probably your best resource out there. Assign one of your team members to work with the family member. While you assess the patient, your teammate is working with the family to try to figure out what's wrong. It could be that because it's taking care of a loved one, they're a little stressed on the problems going on, so they may not be able to focus. So if you even try to calm them down, you might get the answer you need to figure out how to fix the problem. Sometimes the patients are the best source. They know how to operate the equipment. I was working with probably a 6 or 7 year old patient who was on a ventilator, and the ventilator was having some issues. We were bagging the patient, and the patient was telling me how to fix the ventilator. So I had a 6-year-old telling me how to fix the problem that was causing us to have to bag him. So it's a fascinating world we live in, and we use all the resources we can. Here shows the patient telling the guy what to do. They're looking at everything, trying to figure out how to help the patient. They want to stay at home if all possible. If you do have to transport a patient like this, you're going to have to bring the equipment with you because they need to see it at the hospital, then they can try to fix it. Every state scope of practice protocols give you guidelines on what you can and can't do with these special needs equipment. So make sure you're trained in it and you're authorized to do the skills that they're asking you to. Is it a problem with the medical device, and is it life-threatening? If it's a ventilator and it's not working, that is considered life-threatening. But if it's a feeding tube that's not working, maybe that's not life-threatening. You've got time to wait a little bit. Do you have the knowledge to fix it? Just because you stayed at a Holiday Inn last night doesn't mean you know how to fix medical equipment. Maybe you have duct tape and some WD-40, but that's not everything you need to fix the problem. So know what your protocols are, know what your limitations are, and know what you can and can't do. Again, call the help desk number that's on the equipment, and they will help you walk through the process of resetting the equipment or figuring out the solution. For patients with special needs, find out what their baseline is. Find out what normal for them is. Maybe they've got Parkinson's and having shakes is normal. But maybe it's worse than normal. So ask the family. They're your good resource. What's different today, and why did you call 911? They can fill in the details you're not picking up. What happened before you got there? Why did they decide to call 911? Because of the change in the condition. They may be able to do things that you can't do, like reset equipment. So try to figure out what's going on. If you have a patient in your area that you've ran on once or twice, do a little research. Ask the family how you can get more information about their disease because you want to be able to help treat them better. That shows a lot of care for the patient, helps them understand that you're there to help them, and actually improves your knowledge base to help treat the patient. Just because you've got special needs doesn't mean you can get away from your ABCs. So make sure you're maintaining the ABCs. Do a good primary assessment, do a good secondary assessment, looking for your problems that are going to cause the patient compromise. So let's talk about some of the specific diseases that we're going to run into. We may have some that are congenital, so basically at birth, they're congenital heart disease, cleft palate, congenital deafness. Some are acquired or based on some type of medical problem or exposure over their lifetime, such as AIDS, COPD, traumatic spinal cord injury, traumatic brain injury, things that just develop throughout their lifespan. They can be either congenital or acquired, depends on what the background is, but we're going to treat the conditions we find as we find them, try to find out what the acute problem is that made the chronic problem worse. So let's talk about the advanced medical devices we're going to run into here. Some respiratory devices, we've got the non-invasive positive pressure ventilatory devices, could be a CPAP or a BiPAP. We've talked about CPAP, that's an EMT scale. BiPAP is just biphasic continuous positive airway pressure, so it gives you that extra pressure in the lungs during inhalation and exhalation. When you're doing an assessment on a patient, unless the power went out and it stopped and they couldn't get their mask off and they quit breathing, there usually isn't a problem with CPAP. If you do bring them to the hospital, bring the machine with you because they're going to want to assess the settings on it, and maybe they don't have the exact same device at the hospital, and that patient needs that to survive because that's their way to stay breathing at night while they're sleeping. This is a typical CPAP machine, just sits on the nightstand beside them and has a hose and a mask that either goes over the nose or the mouth and nose. Tracheostomy tubes. Tracheostomy is that surgical opening in the neck. It's typically a stoma with some type of connecting tube in it. The trach tube is inserted into the opening, and that's where you put the BVM. If they don't have the trach tube in, then you would put your pediatric size mask on your adult BVM and use that as your ventilation device. Just remember, you've lost all the dead space above the opening if it's a complete tracheostomy. If it's not a complete tracheostomy, as you blow the air in there, it's going to go back up out the mouth and nose and into the lungs. So you have to be aware of what's going on there. They typically have these trach tubes for long-term conditions. It's because it's easier to keep the ventilator going on the trach tube than it is going through the mouth and an endotracheal tube. And they can actually eat and function. Some people have trach tubes that don't have ventilators hooked up to them. I knew a guy that had severe sleep apnea, and their solution was to give a tracheostomy to him. And that gave him a nice complete airway in without worrying about the obstructions from the sleep apnea. If they have that tracheostomy, if it's complete, they will not be able to talk. If it is not complete, they can still plug it up and create airflow across the vocal cords and have some form of speech pattern. One of the problems we run into with the tracheostomy tube is they get mucus in that tube, and it's real simple to suction out with a flexible suction tube. The other problem they run into is infection. So that's nothing we can treat pre-hospital, but we need to be aware of it and consider the signs and symptoms of sepsis. What you're going to do is check the blockage of the tube. If it's blocked, suck it out. If there's any resistance, you're going to use the catheter to go in, clean the catheter between each use with some sterile water. Remember, this is going right into the lungs, so we don't want to be putting things in there that are contaminated or going to be dirty. Use a BVM and keep the head slightly elevated. So lift the head of the cot just a few inches, give them a little extra support there, and that makes their airway much easier. Home ventilators. These are just like a hospital ventilator, but very small and used to mainly be used at home. They are programmed uh, by the hospital or by the respiratory staff before you take them home. So usually they don't have much adjustment to them. Problems you're going to run into, mucus plugs, infection or respiratory distress, or power and mechanical failures. Most people that have home ventilators have a backup power source for them. When that backup power source fails, then they're calling 911 because the only other option is to use a BVM. Use the DOPE mechanism when you're doing your assessment. Displacement of the tube. It's not in the right place. That causes a problem. Obstruction. A pneumothorax or a pneumonia. Something's causing the lungs not to function. That's as simple as listening to the lung sounds. Or we have equipment failure. If you have a problem, make sure the mucus plug is clear, BVM, and secure the ventilator when you get to the ambulance. Most ambulances have a power source in there so you can plug them in once you're in, and then continue using the ventilator on the way to the hospital. We have patients with implanted pacemakers and defibrillators. The implanted pacemaker goes in under the skin, typically on the upper left chest, right about the mid-clavicular line, or they could put them in the abdominal cavity. They have wires that go to the heart, to the various portions where they would need a stimulus for cardiac output. So they will do a low energy pulse, 60 to 80 times a minute, whatever it's set for, and it sends that to the heart. It's typically such a low voltage that the patient doesn't feel it. It just is just like the heart, the SA nodes kicking in. Some people have a combination automated implanted or automatic implanted cardiac defibrillator. They're under the skin, same type of location. They're a little bit bigger, but they have wires that go directly to the ventricles. And if it detects VFib or VTAC, they will get a shock. And they will feel this shock. It is enough that they will feel the jolt in their chest. Typically, the patient goes unresponsive for about two or 3 seconds, and then they get this shock. If you have a patient that is getting shocked, you need to bring them to the hospital. There is a reason they're getting shocked, and this is keeping them alive until we correct that problem. So call ALS, get them to the hospital, make sure they have lots of oxygen. If they go into cardiac arrest, their implanted pacemaker defibrillator is not working, and we treat them identical to any other cardiac arrest patient. There's no changes just because they have something implanted. They do make a vest that has a defibrillator built into it that the patient can put on and wear that, and it has pads that attach to the test just like an AED. But it's just a wearable device. It's like a wearable AED. You can do CPR on this. It will actually give you directions on CPR. It's like I said, it's just like an AED, but it's a vest form. So they've got it on 24 hours a day or however long they have to wear it. We do have ventricular assist devices. These typically are pumps that take the blood from the left ventricle out a tube and then comes back into the heart and pushes it through, back through the vascular system. So it's a very, it's kind of like an external heart, for lack of better words. Problems you run into are battery failure. That could be a bad thing. Air leakage, infection. If you have a ventricular assist device, they'll have an external battery pack. Make sure that's good. If it fails and you don't have an AC outlet to plug it into, you will use a hand pump. They typically have a crank built into them, and you crank that 60 to 80 times a minute. These are patients that are waiting for a transplant, and the healthcare people that are monitoring them typically meet with the local EMS providers and say, hey, I've got a patient at 1313 Mockingbird Lane. This is what the device is. we're going to stop by your station so you can meet them and see the device and make sure everybody's on the same page with what's going on. So if they go into cardiac arrest, you don't do CPR because the heart is not the pump. The pump is outside with the hand crank on. This is what it looks like. If you see Coach here with in cardiac arrest, you turn the crank on and you do like the organ grinder and crank the tune. If it plays the theme to a Jack in the Box, you've got the wrong crank. Other devices we're running into is gastro-urinary devices, or they have feeding tubes. They have NG tubes. They go through the nose into the stomach. Those are temporary. They provide nutrients down into the stomach. A G tube goes through the abdominal wall. These are more long-term. Same type of process as an NG tube, but just direct and more long-term. Problems you're running into is it comes out. It gets clogged because they didn't flush it after they gave them their food, or you get some type of infection at the insertion points. When you're dealing with a patient with this, you're transporting to the hospital, you typically do not have to add anything to it. If they're in the middle of a feeding, just keep the bag above the patient, put the cap on it, and transport it with them. There's nothing special about it. You just don't want to pull it out or disturb it. Here's showing get the kiddo his lunch there. They've just got a syringe. They pour the food into it, and it flows into the stomach. Urinary catheters. Typically, these are Foley catheters that go in through the urethra into the bladder, and then they inflate it with saline, and there's a balloon on the inside of the bladder that keeps it from coming out. It drains out a tube into a bag that's either strapped to the leg or hanging down below the patient. Again, problems you run into are infection, blockage, discolored urine from some type of infection. Much easier to see if it's stuck in the bag, and it gets pulled out. So what you want to do is keep the bag below the patient. Remember, it's draining through gravity, so it's going to be below the patient. Don't step on it or don't drag the cot over it. What you want to do is if you have to transport, you're going to try to empty it and document what you empty and how much. Document the color and any odor you smelled when you did dump the urine. Here shows the guy's got his catheter bag attached to his walker there. That's probably enough you could transport and not worry about it, but if it was more, you'd probably want to dump it before you get in the ambulance so you don't have any messes. Ostomy bags. A colostomy is a hole directly into the intestine. You typically don't see these. They're taped to the body, and the fecal matter is coming out through the ostomy into the bag. Problems you run into is blockage or dislodgement. This is not an EMT skill. You just basically take them to the hospital if you have it. You don't want to mess with them. Dialysis, we've talked about. We've got the hemodialysis where you've got the patient at a dialysis center where they're using the machine to take the blood out, clean it, put it back in. Complications are infection or hypovolemia. The peritoneal dialysis we talked about. You have the catheter that goes in the abdominal cavity, puts the fluid in there through osmosis, absorbs the bad waste in the belly, and then you pull the fluid out. If you have a patient's bleeding, you stop the bleeding. Don't take a blood pressure in the arm of the AV shunt. And if you have, you treat for shock. We have people that have long-term medical care through IV therapy. So you're going to have central line care, IV ports. Typically, it's a port on the subclavian. So you'll see the tubes hanging out just on the upper chest. If you have any bleeding from that area, apply direct pressure. Same with the peripheral. They put the tubing in and secure that to the arm. They might have 2 or 3 tubes. These are not authorized for EMTs to use for IVs. So we have to be careful of that. Sometimes they have a implanted port just below the skin if they're like a chemo patient or some type of long-term therapy. Those are not accessible to EMTs either for IVs. If you have bleeding from it, direct pressure. The other thing is don't put the AED right over it. You may have BP shunts. These are drainage ports coming from the brain or the spine. So you get that excess cerebral spinal fluid to drain out, so you reduce the intracranial pressure. If they get clogged, you have an increased intracranial pressure, which means you have an altered mental status. They also are prone to infections. So then you'd have a meningitis infection there. So be aware of that and transport your patients appropriately. There's not any treatment you can do for these patients. You manage what you find, make sure they've got good oxygen, and you're transporting to the appropriate facility. If they have some type of physical impairment, hearing, sight, speech impairment, adjust how you're doing your care. Maybe you have to talk to them directly. Maybe you have to pull your mask down so they can see your lips because they need to be able to hear you. Maybe you write your things down. Use your phone to translate. A friend of mine has a iPad that she types in what she's wanting to say, and it will say it to you, so you can actually understand what she's trying to say. So there's all kinds of options out there. Just remember, just because they can't communicate doesn't mean they have a mental impairment. It just means they have a communication impairment. Maybe they have sight issues. Um, Help them understand what you're doing. Tell them when you're going to do and when you're going to touch them, so they know because they can't see it coming. If they do have a guide dog or a medical assistance dog, that dog is part of them and they come to the hospital with it. So bring everything you need to. Sometimes they can't speak correctly. So that, like I said, they have that tablet to help them say what they need to say. Maybe they have difficulty walking or standing. They've got some type of impairment. If they have a wheelchair, make sure you bring it to the hospital with them. That is their lifeline. It's one thing we found out during evacuations for wildfires. If we grab the patient, put them on an ambulance cot, and take them to a shelter without their wheelchair, they've lost their functions in life. They need that chair to get around. They have special attachments to it that help them live a normal life, and you just took that away from them. So make sure you bring the wheelchair with you to the hospital. If they have any special needs, make sure that you're trying to take care of them. Get a special a baseline. Make sure you ask them what they need to be comfortable and what they need to maintain their normal lifestyle. Ask them what normal is for them. And if you have any special needs equipment, bring it with you. That's just common sense. You would want to bring everything you need to live a normal life with you to the hospital. So let's talk about something that happens occasionally, or actually more often than not, more often than it needs to happen. The abuse and neglect of our patients that have special needs. So abuse and neglect, people with special needs are more vulnerable. Children are more vulnerable to this. So we need to be aware of what's going on around our patients. Get a good scene size up. One thing that's really helpful is if your system does this, when someone calls 911 and there's a special needs or a pediatric patient, you probably should bring law enforcement with you just for assistance on the scene. When a person calls 911, they're asking for public safety to come in and help take care of their problem. That way the law enforcement is being invited in, and so if they see something, they can document that at the time of. They don't have to go through the warrant process and get the authorization from a court to get in. So you give them an opening to try to help solve these problems at the time. What you're looking for are stories that just don't make sense. Something just tells you this didn't happen the way they said it. They could be embarrassed and lying about it, but that's not yours to decide. All you have to document is that the story was inconsistent and you're suspicious, and then the law enforcement and the Department of Human Services will take over and try to figure out injuries that are in multi stages of healing. So they've got bruises that are various healing stages, repeated injuries, or the stories don't match. Caregiver tells you one thing and the patient tells you another. We are not making accusations. We are not accusing anybody. We get the patient to the hospital and have them help us figure it out. As EMTs, you're required by law to report suspicions. That can be as simple as telling the hospital when you get there, or like I said, if law enforcement comes with you, make sure they understand that you have some concerns they need to investigate. Let's talk about child abuse first. Psychological or emotional abuse, just not being cared for, neglect. They may have physical abuse or sexual abuse. Neglect is they just aren't provided food or shelter or safe environment. Maybe somebody saw the kids digging out of the dumpster, or they're always going to the neighbor asking for food. Maybe you just got a hungry kid. Maybe the parents haven't been home for a month. Both causes for concern, so make sure that's passed on. Physical abuse, you have the object that's causing the injury doesn't match what the injury looks like. Maybe it looks like a wooden spoon, but they said they fell down. Or maybe it looks like a hand mark. Burns that don't match up, or that match up too well to other things like curling irons or cigarettes. Be aware of what's going on. Injuries to the genitalia that just don't make sense. The maturity level that doesn't make sense for a child. They use terms that are not typically used by a child that age. Common findings you're going to have: slap marks, bruises, lacerations, broken bones, fractures that don't make sense, head injuries that aren't consistent with the source of injury, bite marks, burn marks, increased intracranial pressure on a child, shaken baby syndrome, always bad. Repeated visits. Fortunately, because of the location of fire stations, they typically have the same crews responding to same geographical areas. In larger systems, your ambulance may not be in the same area twice, so you might not have the ability to piece these things together. It may have to rely on the hospital to say, hey, we've had this patient 4 times with similar injuries. Indications of past burns or bilateral burns, different body parts injured, unusual behavior, or a caregiver that just won't leave the kid alone. They're very protective, or maybe the kid's showing some signs of he's not comfortable with the caregiver around. So observe the adults. Are they concerned, or are they not? Are they not concerned? Now, if the adult caregiver is a EMS provider and they don't act like it's as bad as you think it is, maybe they've seen this before and it's not as bad as you think it is. I know I've been accused, not accused for child abuse, but by my wife, that I didn't show as much concern for injuries that she thought I should have, because they weren't really that serious. Maybe the caregiver isn't able to control their anger, has emotional outbursts. Something's just not right. Make sure you pass that on to the further care providers and to the law enforcement. If you have any suspicion of sexual abuse, treat that just like any other sexual assault. Do not undress the child. Do not let the child go to the bathroom or shower. Pass that on to the hospital and let them use their assessing skills to document everything you find and make sure that's taken care of. Remain professional and control your emotions. No matter how much you want to give some retribution to the abuser, do not do that. That'll just get you in trouble and complicate the case. So just tell the child you're going to take care of them. You're going to get them to the hospital. It's not their fault, but you're going to try to take care of them so that things get better here. If you have any type of injuries, you're going to address them appropriately, but document everything you do. Keep them from going to the bathroom, nothing by mouth. Don't let them wash and transport. Sometimes we have elderly abuse and neglect. These are the same type of things you're going to run into, but we add financial abuse. So we have physical, psychological, financial, and just neglect. Think about the geriatric patient now is coming back to live with their adult children. They're putting extra stress on them and creating more issues for their lifestyle, and it gets too much, and they have emotional outbursts. Maybe they try. This happens a lot. Family members or not, the financial abuse. They use the money inappropriately. They skim it off the top. There's lots of things. If something just doesn't seem right, make sure you report that and pass that on to the authorities. There are all kinds of other abuses out there, also with people that have disabilities. They may be taken advantage of because of who they are and the fact that they can't say anything. And we need to stand up for our patients. We're our patient advocates. If you see the clues, document it and pass that on to the appropriate authorities. Warning signs, unexplained absences of caregivers or potential harmful periods of abandonment. They haven't seen their caregiver for a week. They haven't eaten. They haven't been able to get up and use the restroom like they normally would. The caregivers just don't act right around them. They're getting conflicting information on what you're seeing and what the caregiver tells you and what the patient tells you. Gather your information, document the facts, don't put opinions in. Don't say you suspect there's abuse, just say, hey, once I get to the hospital, I'm going to tell the doctor what I've got here and let them figure it out. In some states, and Colorado is one of these, you have to report any type of abuse. So you notify the law enforcement or the hospital. Know your system. Some states require you call social services. But you have to report it. You have to take care of your patient. Could be intimate partner violence, spousal abuse. It's what it's called. Physical, emotional, economic, sexual abuse. If you have any suspicions about abuse, or if they tell you about the abuse, make sure you document that and pass that on to the next level of healthcare or the law enforcement. What you want to do with these patients that may be potential abuse patients, get them away from everybody and do the interviews where you can in a little privacy. What you're looking for are signs of physical abuse. The victim is fearful from talking to you. You need to make sure they understand you're there to help them, and you're going to make sure they have what they need. They may not be wanting to go to the hospital, so you need to try to convince them. Use some good active listening and understanding what's going on, and pay attention to how their people around them are reacting, their partner, and how they're kind of protecting them from you or isolating them from you. So take care of the medical issues first. If they refuse care, make sure they understand there's lots of options to help them. There's a lot. They can always call 911 again. There's substance or abuse hotlines. There's shelters they can go to. Make sure you know what's available in your system. When you do document it, make sure that you're very thorough in your documentation. Make sure you only do the objective findings. You don't do any opinions. and that you provide as much information as you can so that the hospital and the law enforcement can figure out what to do. Another thing we're starting to run into a lot is the human trafficking. Trafficking is the exploitation of a person for compelled labor or commercial sex acts through force. We are seeing these victims kept in very tight quarters, being sold out for different abuse situations. You may get these calls for somebody that's not doing well, that something's wrong, and things just don't add up. You have bruises, very similar to what you had in any other abuse case, but you have scars. They typically brand the human trafficking victims. They'll have tattoos of a guy's name on them. That's their pimp or owner. They have UTIs. They're pregnant. They have STDs, chronic back pain. They're not well kept physically, but they're very well kept fashion wise. You'll see children that probably aren't old enough to have the clothing that they have. They have makeup. A friend of mine worked at a women's lingerie store at the mall, and she was also worked for CSPD in dispatch, and she was all the time seeing older men bringing in young girls to get various things of lingerie that just didn't seem right. And they were always, she was getting information and passing it on and finding out they were actually being human trafficked. And they would track down those clients that were coming through. Other indications, that, like I said, the controlling person there with them, they do all the talking. They don't let the person talk. Their IDs probably don't match them. They're very submissive or fearful. They're not dressed appropriate. Like I said, they're wearing things that just don't make sense. So treat the medical stuff first. If you suspect it, let law enforcement know immediately. Be careful how you do it, because this can be a danger to the victim. If they think they're being the handler is under any suspicion, they'll take it out on the victims. They have special task force for child trafficking here in Colorado, and I'm sure they do in every other state. So use the resources. And with all of this, if you suspect something, say something. Pass it on to the healthcare providers at the hospital. Pass it on to law enforcement. Only document the facts, what you see and what doesn't make sense. Say, hey, this doesn't make sense. I need to have someone look at it further, and go with that. And as always, if you have questions, concerns, or thoughts on how to make this better, reach out. Let somebody know. Bring it to class and let's talk about it. Thanks, and have a great day.